keynote speaker to the Mendelson Center's annual Alzheimer Day. We can thank the Mendelson family for today's keynote speaker, Dr. William Jagust from the University of California, Berkeley. Thank you, Mendelson family. We would also like to thank the Miller family for their generous support of this event. Since 2008, Glenn and Wendy Miller and their daughter Lauren have supported the Glenn and Wendy Miller Family Buddy Program, which was named in their honor in 2021. In addition, they helped establish the Glenn and Wendy Miller Family Postgraduate Social Work Fellowship in Neurocognitive Disorders. Thank you, Miller Family Foundation. I would also like to thank our sponsors for their generous support, especially our platinum and gold sponsors, Peck Ritchie LLC and Eli Lilly. And these are all of our sponsors listed here. Please visit them during the afternoon poster session. Thank you, sponsors. And finally, I'd like to thank our dedicated Alzheimer's Day planning team led by Dr. Darby Morehart. The members of this fabulous team are Eskadar Alam, Bobby Bobbitt, Lauren Dowden, Nicole Hunt, Ashley Knight, Kate O'Neill, Felicia Stokes, and Phyllis Timpo. And I also need to thank the entire Mendelson Center staff and faculty who have made this day possible. Thank you, team. So now I'd like to give you an update on the progress of the Mendelson Center since our last Alzheimer's Day last year. You'll be pleased to know that the current year has witnessed exceptional growth and progress. Components of the Mendelson Center are all thriving, including the NIH-funded Alzheimer's Disease Research Center, the Superaging Program, the Primary Progressive Aphasia Program, Communication Bridge, and the Glenn and Wendy Miller Family Program. Communication Bridge, a person-centered internet-based intervention for individuals with primary progressive aphasia, led by Dr. Emily Rogalski, has been renewed by the NIH. Additionally, Dr. Borna Banaktapur was awarded a grant from the National Endowment for the Arts on the effectiveness of music on anxiety in individuals with mild to moderate Alzheimer's disease. The Alzheimer Research Center, founded by Dr. Mesulam in 1996, continues its 6th cycle of funding for years 25 through 30 under my leadership and that of Associate Directors Drs. Sandra Weintraub and John Disterhoft. The Superaging Program, a multi-center consortium under the leadership of Drs. Emily Rogalski and Shangiz Geula, is advancing our knowledge of superior cognitive aging. The Primary Progressive Aphasia Research Program, now into years 15 through 20, and led by Drs. Mesulam and Rogalski, continues progress toward understanding this devastating dementia. We look forward to continuing these iconic research programs of our center into the years ahead. The Glenn and Wendy Miller Family Buddy Program that matches persons living with dementia with students and fellows continues to flourish and expand under the leadership of Dr. Darby Morehart and her team, and remains a favorite endeavor among its participants. The research education component of our Alzheimer's Disease Research Center, led by Dr. Geula, has continued its mission of training and education. A recent addition to the research education component is the Brain Scholars Program, with the goal of training the future research workforce with a concentration on underrepresented groups. In partnership with schools on the south side of Chicago, this program provides exposure to research and clinical aspects of aging and dementia, and in its short period of operation has engaged over 60 students from underrepresented groups in activities related to this field. And on Saturday, October 8th, the Mesulam Center participated in the Alzheimer's Association annual Walk to End Alzheimer's at Soldier Field. We had our largest team yet with 56 participants and raised over $16,500 to support Alzheimer's and dementia research. The new Mendelson Center Neurobehavior Clinic on Archies 13 continues its mandate to serve dementia patients and their families. At the clinic, neurologists, neuropsychologists, psychiatrists, and social workers all work in the same space, a unique situation where care providers can talk to their team members down the hall about patients and get immediate answers. The new clinic doubles our space and will enable new and expanded clinical programs. Recruitments and promotions are central to academic life, and I'm delighted to report that Dr. Tamar Geffen was named as Clinical Core Co-Leader of our Alzheimer's Disease Research Center. In addition, Dr. Rudolph Castellani was promoted to Neuropathology Core Leader. Both these roles are critical for the center's research on the causes of dementia. Dr. Borna Bonakdapur was promoted to Associate Professor of Neurology. Drs. Weintraub and Morhart were both appointed to the Illinois Supreme Court Commission on Elder Law. Dr. Maureen Daly was named Associate Director of the Master's and PhD degree programs in Clinical Psychology. Dr. Elena Barbieri joined the Mendelson Center as a Senior Clinical Research Associate on the Primary Progressive Aphasia team. Last but not least, Dr. Mendelson was honored at the French Society of Neurology Awards with the designation of Member of Excellence in recognition of his important contributions to neurology, research in neurology. It is no secret that patient care and basic research on Alzheimer's disease are subject to major social and cultural influences. Healthcare disparities remain to be addressed more creatively, and diversity in research remains a goal to be attained. Phyllis Timpo, Senior Community Engagement Coordinator on Dr. Morhart's team, joined the center last year to develop relationships in Chicago neighborhoods with high populations of Black and older adults. These efforts are critical for participant recruitment into studies to understand why the incidence of dementia is higher among underrepresented groups. Under the guidance of our center administrator, Eskadar Alem, center committees were reactivated and reorganized. These included committees on diversity, equity, and inclusion, staff relations, and the underrepresented group recruitment and retention task force. The center is committed to addressing diversity and healthcare disparities into the future. The future of dementia research and care is bright, and the Mendelson Center will continue to work diligently to advance the understanding of dementia and how to mitigate the effects of these devastating neurodegenerative disorders. New hope for Alzheimer's disease has recently come from the successful clinical trials of the amyloid immunotherapies called lecanemab and donanemab. Although there are possible side effects associated with these immunotherapies, they represent the first disease-modifying therapies for Alzheimer's disease that affect the underlying biology of the disease, of the disorder. These amyloid immunotherapies are not the end, but just the beginning of disease-modifying treatments that are in development for Alzheimer's. Much work in the years ahead will be required to test different therapies that attack targets besides amyloid. We must also understand the basis of observed side effects and learn who would benefit the most from these new therapies. There is much work left to be done in dementia research and care, and the Mendelson Center will continue to be leading the way. Now with that, I want to thank you for listening, and now we'll proceed to the next part of our event, in which the award, which is the award of the Marie and Carl Duncan Prize in Memory Disorders Research, and the award will be presented by John Disteroff, who's professor of neuroscience here at Northwestern, and also associate director of our Alzheimer's Disease Research Center. Thank you, John.
Thanks, Bob. It's great to have the opportunity to present the Marie and Carl Duncan Award again this year. And it's also nice to see that we have a full house. The poster session is an important part of AD Day. And this year, we have actually a record number of posters, so 83 posters. They're all in your program book, and I can give you a hint of how to go through those posters. Each one of them has a lay summary, so that's a good way to kind of pick out. It's unlikely that you're going to be able to see all 83 posters, but maybe you can pick out the ones you're particularly interested in. So we had a committee that went through the 83 abstracts, ranked them, and we picked the top poster, and then we have 3 runner-ups that followed those, were next in line. And before I present the poster, the prizes, I'd like to just briefly mention the history of the Duncan Award. So this is an award to celebrate the work, acknowledge the work of Carl Duncan, who was a professor in the Department of Psychology in Evanston, who did important early work on memory consolidation, which is the formation, the permanent formation of new memories, which is, of course, something that is very much impacted by Alzheimer's disease. Carl Duncan was a colleague of our deceased colleague, R.A. Rutenberg, who established the award to start with. So it's so that's the history of the award. And so let me start by announcing the winner of the award. And if he is here, please come up and I can give you the plaque. So it's Ivan Ayala, and I don't know if Ivan, I think, yeah, okay, great. So you've heard a little bit about the SuperAger program that's part of the Mendelson Center, and Ivan's poster is entitled Cognitive Superagers Are Protected from Phosphorylated Tau Accumulation in Basal Forebrain Cholinergic Neurons. And the other thing I'd like to mention is that Ivan is working in the laboratory of Changiz Geula, Dr. Geula. So, Ivan, congratulations. And it was difficult to go through and rank all of these posters. And as it turns out, we had 3 posters that were ranked equivalent, so as the runner-ups. And so let me announce those. And again, if the winner is here, please come up and get it. One of the runner-ups is Grace Minogue, who, and the title of her poster is Stereological Densities of Corticobasal Degeneration Neuropathology Are Anatomically Distinct in PPA and BV FTD. So, Grace. Congratulations. The second of the runner-ups is Erfan Tayfai, who is also working in the laboratory of Changiz Geula. The title of his poster is Increased Production of Reactive Oxygen Species by Human Microglia in Superagers in response to soluble oligomeric and fibrillar amyloid beta peptide. That's a mouthful. So, congratulations. And our final winner is Antonia Zuridakis, who, like Grace Minogue, is working in the laboratory of Tamar Geffen, and the title of her abstract is Anatomic Selectivity of Neuronal and Glial Tau in Primary Progressive Aphasia with 4R FTLD tauopathies. So, Antonia, congratulations.
Thank you so much.
I think, who is, well, okay, you can.
It's your turn.
Okay.
Well, let me introduce you first.
Yes, please.
All right, So thank you very much, John. That was great. And congratulations to all the award winners. You're doing a great job. So now on to our Mendelson lecture. And it's my pleasure to introduce our keynote speaker for Alzheimer Day, Dr. William Jagust, who is professor of public health and neuroscience at the University of California, Berkeley. And he is also a faculty senior scientist at Lawrence Berkeley National Lab. He was previously the chair of the Department of Neurology at the University of California, Davis, and was the founding director of the UC Davis Alzheimer's Disease Center. Dr. Jagust has focused his career on understanding the aging brain, and particularly the borderland between normal cognitive aging and Alzheimer's disease. His laboratory has pioneered the use of multimodal imaging to understand brain aging in Alzheimer's disease, employing positron emission tomography to measure beta amyloid and tau proteins in the brain, and magnetic resonance imaging to investigate how these protein aggregates affect neural function and structure. He served on the editorial boards of major journals, advisory boards on the National Institute on Aging, and the pharmaceutical industry. His laboratory leads the positron emission tomography of numerous multi-center studies, including the Alzheimer's Disease Neuroimaging Initiative, the Pointer Imaging Study, SCAN, and the HEAD study. He is a recipient of the 2013 Potamkin Prize for Research in PICS, Alzheimer's, and related diseases. So without further ado, I give you Dr. Jagust. The title of his talk is New Insights into Alzheimer's Disease. Will they give us new treatments? Take it away, Bill.
Thank you, Bob, and thanks to the Mendelson Center folks. It's a real honor to be here. Bob already told you about Marcel Mendelson, but I just want to say a word. I was when I was a young neurologist, I read a lot of his papers, and I just want to say they were an inspiration to me. I think many people in my generation of neurologists feel the same way. I know there were hundreds of people around the world who were influenced by his work, and it's certainly one of the reasons I ended up going down the particular pathway I did. So I want to talk to you about our sort of model of what Alzheimer's disease is. We have an idea of what it is. We can define it in different ways, but it's a complex entity, and you've probably heard a lot of the terms that I'm going to throw around today, like amyloid and tau and atrophy and neurodegeneration. I'm going to try to put meaning to those words and explain to you how our understanding of those processes have led to our current concept of what we think Alzheimer's disease is on sort of a biochemical level, and how maybe that is finally leading to effective treatments. So I want to start with something totally out of left field, and that is cardiovascular disease. And you know that this is sort of the graph of the prevalence of cardiovascular disease from the early 20th century till relatively recently. And what you can see is that early on in the 20th century, there was an increase in people dying from heart attacks and strokes. And we don't precisely know what caused that, but it was probably the fact of longevity. People were living longer, diets were changing in bad ways, more people were smoking, there was sedentary lifestyle, and so forth. And the peak of cardiovascular mortality was really probably in the middle of the 20th century, and since then it started to go down. And well, why is that? Well, studies began. You've probably heard of the Framingham Heart Study that identified risk factors like high cholesterol, hypertension, cigarette smoking. There were clinical trials of drugs that lowered blood pressure, hypertension, and treated high cholesterol, and those drugs came out in the late 50s. There were more cholesterol drugs later on. And over time, there was a decrease in cardiovascular disease. As you see, a lot of it probably was also due to smoking cessation programs. So I think this is, we're not done with this. There's heart attacks and strokes are still huge public health problems. But I want to point out that we were successful here with a very, very complicated disease, but it's taken 70 years. And we can't wait 70 years to get there in Alzheimer's disease. So what's Alzheimer's disease? Well, it's a form of dementia. Dementia involves the loss of cognitive function, difficulty with performing activities of daily life. All dementia is not Alzheimer's disease. There's other causes of dementia, but a very large majority of dementia is Alzheimer's disease. And it usually begins with loss of what we call episodic memory, that is, memory for the events of a person's life. And people who have this kind of memory loss can't remember things that have happened to them recently. They can't make new memories. And over time, this gradually progresses to a rather severe, as we all know, and pervasive cognitive loss. And I just want to draw attention to another concept called mild cognitive impairment, which is a frequent precursor to Alzheimer's disease. It involves loss of memory or other cognitive ability that's generally milder, but it usually predicts Alzheimer's disease and is frequently followed by Alzheimer's disease. So I'm going to use these terms a lot. So it's easy to define Alzheimer's disease in one way, and that is if a person suffers from dementia during life and has these characteristic pathologies in the brain when they die, we say they have Alzheimer's disease. And one of those pathologies is this beta amyloid protein, which occurs in the amyloid plaque. And the other is the tau protein, which occurs in this neurofibrillary tangle. And these plaques and tangles, as we call them for short, occur throughout the brain, but they have very characteristic locations in the brain. The tau neurofibrillary tangles occur in this part of the brain, which is actually in the medial temporal lobe. It's the memory system of the brain. And this is where we see the tau early on and probably where it begins. And the amyloid, in contrast, is deposited throughout the brain. And these pathologies are very common as we get older, and they're not invariably associated with symptoms. So these are graphs of how prevalent the tau pathology is in purple and the amyloid pathology in green. And you can see by the time people get into their 70s and 80s, almost everyone has these tau tangles, but they're pretty much limited to the medial temporal lobe, this memory system in the brain. I probably have some. The amyloid is less prevalent, but also increases greatly as we age. So these are very common in the brains of older people, but when we see them in the right places of the brain and in the right settings, we say that in the context of dementia, we say that the person had Alzheimer's disease. Well, let's try again. Okay, so I'm just going to, I shudder to present slides on molecular biology with Bob Vassar in the room. He's the world's expert on this, but I'll do it anyway. So this amyloid protein we call A beta. It's a part of a much larger precursor protein called the amyloid precursor protein, and it's cleaved to form this A beta molecule that floats around in the brain and then aggregates to form these plaques, and we think somehow that causes the tau tangles. So this is really a pretty simple idea. It's way more complicated, but the basic idea is that this amyloid A beta is cleaved from this larger protein. What's really interesting is the genetics of this, and that has taught us a great deal about Alzheimer's disease. The first point is that this protein is coded for by a gene on chromosome 21. Now, people have problems with chromosome 21. When they have 3 copies, they have trisomy 21. It's also called Down syndrome. And people who have Down syndrome develop Alzheimer's disease. And we think they develop Alzheimer's disease because they're making too much of this amyloid because they have 3 copies of the gene. But it's more than that. There are mutations that are inherited in families that cause autosomal dominant Alzheimer's disease that all occur in this precursor protein, or in some cases in these enzymes that process the precursor protein to produce that A beta fragment that causes the plaques. So all of these autosomal dominant or inherited forms of Alzheimer's disease are associated with alterations in how this precursor protein is processed, and they increase the amount of amyloid or A beta in the brain. And there's a 4th gene called apolipoprotein E that's a risk factor, and that also increases the amount of amyloid in the brain. So all of this, the trisomy 21, the family mutations that increase amyloid and cause Alzheimer's disease, has led to this idea that we call the amyloid hypothesis of Alzheimer's disease. And this has been the driving idea behind Alzheimer's disease for well over 20 years, that somehow this amyloid accumulates in the brain. Now, in most cases, we don't have these gene mutations. These gene mutations I'm talking about are extremely rare. They account for a vanishingly small proportion of all the Alzheimer's disease in the world. But they've created this model that tells us that all you really need is to have this amyloid and then everything else follows. All the bad stuff happens afterwards. So it's been very influential, and it's led to this amyloid hypothesis. And this amyloid hypothesis has been very controversial. If you read the newspapers, it gets into the media. The amyloid hypothesis is wrong. And the only way we're going to know for sure if it's right is if we can get rid of amyloid and make Alzheimer's disease better. So one of the exciting things that's happened in my career is that in the last 20 years, we've been able to image amyloid with a PET scan. And I'm not going to go into the technology very much. All a PET scan is we inject a small amount of radioactivity that binds to the amyloid protein in the brain and allows us to see it with a scanner. It's very, very simple, pretty straightforward. And here's a patient with Alzheimer's disease, and the red hot colors are areas in the brain where the amyloid is. And here's a patient from my lab who is cognitively normal. And there's none of that red color because there's no amyloid in that person's brain. But here's another person from my lab who also had a PET scan, who is also cognitively normal, and who also has amyloid and looks pretty much like the Alzheimer's disease patient. And I want to assure you that this person was normal. We study these people in my lab with long cognitive test batteries. We really stress their brains, and we can't detect changes in most of them. And yet they can have a great deal of amyloid in the brain. And I don't want to go through all the numerical data, but these purple dots are the normal subjects in my lab. This is the amount of amyloid in the brain, and you can see many of these individuals have a lot of amyloid in the brain. About 30% of people in most studies, not just in Berkeley, but around the world, about 30% of healthy older people in their 70s or 80s have amyloid in the brain and don't have cognitive problems. So this is the first argument about amyloid. Well, it can't be right. Let me tell you about the other biomarkers. So amyloid, I just told you about, we can measure with a PET scan. It's too much drinking and smoking last night. Not really, I don't do any of those things. So this is an amyloid scan. Again, like I showed you, you can also measure amyloid in spinal fluid, so you have to do a spinal tap. And as I'm going to tell you at the end of the talk, we are actually now able to measure this in blood, in plasma. Tau now we can measure with a PET scan. So this is a PET scan of tau, showing you the hot areas where there's tau in the brains of a person with Alzheimer's disease. And again, we can measure this with PET, we can measure it with spinal fluid, and we can measure it with a blood test. And then the third part of the Alzheimer's disease story is what we call neurodegeneration. That's generally shrinkage of the brain. That occurs in many neurological diseases. It's not specific to Alzheimer's disease. It occurs in Alzheimer's probably because of this pathology that's accumulating. We can measure it with an MRI scan or with a certain kind of PET scan that measures glucose metabolism. So that's neurodegeneration. And I put these A, T, and N next to it because this is essentially a characterization of our participants in all of our research studies now around the world where we're characterizing them for amyloid, tau, and neurodegeneration. Okay, so we have this amyloid. and it has a weak relationship to cognition. It has to have a weak relationship to cognition if you can have amyloid in your brain and be intact cognitively. So what's going on? Well, what's going on is these other processes that I've been telling you about. That amyloid is doing something to tau, and that tau is doing something to the brain to cause it to shrink, and these processes are inducing the neurodegeneration. And so this is the model for Alzheimer's disease in a way, and that has led us to where we are now. And it's really not that complicated, right? I mean, if you think of any risk factor or any biomarker you can measure, that biomarker has downstream effects that cause the end process, and this is our idea of the steps in what we call the pathological cascade of Alzheimer's disease. So I want to take you through just a little bit of the evidence for this. I'm not going to spend a whole lot of time on this, but let's look at this amyloid tau story. So this is a map of where the tau is in the brain of older people, and we measured the tau with PET scans, and we simply looked at this data, and we said, as you get older, tell us where the tau is. We asked the PET scans to tell us that. And what they did is they showed us these brain regions here and here, which are the medial temporal lobe, the memory centers of the brain. And that's just what we had known from pathology studies for decades. We knew that as we get older, you get tau in that region. And you can see that with the PET scan, that as we get older, we get tau in that region. And then we said, okay, let's hold age constant. And where does the tau appear when amyloid gets deposited in the brain? And it's a way different picture. Don't really pay too much attention to the colors, but we see the tau now, not just in these medial parts of the brain, but out on the surfaces of the brain, out on the lateral surfaces of the brain, throughout the whole brain. And so this led to the idea that amyloid is doing something to trigger the spread of tau out of that medial temporal lobe area into the rest of the brain. And that's when people begin to develop cognitive symptoms that are significant. Let's look at this part. Now, it's a little hard to take this all apart because tau is related to cognition and neurodegeneration is related to cognition and tau is related to neurodegeneration. So I just want to show you two experiments we did. So this is a study of people with Alzheimer's disease where we basically looked at baseline amyloid here. PIB is the way we measure amyloid. Baseline tau here, and FTP is the way we measure tau with the PET scan. And baseline cortical thickness here in a group of people with Alzheimer's disease. And we said, given these baseline measurements, can we predict how much the brain is going to shrink over the next 5 years? And so if you look at the baseline amyloid, the more amyloid you have, the more the brain shrinks. The higher the slope here means the brain is shrinking more. So the amyloid is correlated with brain shrinkage, but it's not that strong. And here's the brain shrinkage, and so we're asking, well, the more your brain has shrunk, is that right? Has shrunk? Anyway, the more it's going to shrink. And that's correlated too, but not very strong. But obviously, you see the punchline coming. The more tau you have in the brain, the more rapidly your brain is going to shrink over the next 5 years. And so tau is the best predictor of brain degeneration, and that's a problem that's very close to the issue of developing memory loss. Oops, so that slide didn't show, but here is just another example of tau now showing how memory changes over time. And here we're looking at a tau scan at baseline and asking the question, where does the tau predict the subsequent change in memory? And here we see it again in these medial temporal lobe brain regions, right here. So the more tau you have in this part of the brain, the more memory is going to decline over the next several years. But there's also this other spot here, and this spot only shows up in people who have amyloid in the brain. So that when you have amyloid in the brain, the amyloid outside that, the tau outside that brain region also predicts cognitive decline. So we have tau predicting brain shrinkage, we have tau predicting memory loss, and we also have brain shrinkage predicting memory loss. I didn't show you that. And we think all of that whole process, all those downstream events are being driven by amyloid. So this is a very simple cartoon of what we think Alzheimer's disease is. And we think older people develop this tau in this medial temporal lobe brain region. We're not sure why that happens. We're not sure about a lot of the things I'm telling you, actually. And we think it's a benign cause of memory loss. When I say we're not sure, I mean it all has to be tested. But to me, this is a great set of hypotheses. I don't want to trash talk it. So we think this tau in the medial temporal lobe, this tau in these brain regions, are a relatively benign cause of memory loss. We don't understand how the tau gets there. We don't think it's generally associated with terrible outcomes. But then amyloid comes along, and the tau, something happens to the tau. It changes, and it spreads out through the rest of the brain. And that is when cognitive loss begins, serious cognitive loss. That's when dementia eventuates. And that, we think, that event, in a way, probably takes a long time, is the beginning of Alzheimer's disease. Okay, so this whole story is sort of the backbone of our current hypotheses about Alzheimer's, and it's led to many, many things. Many ways we do research have changed. But the one I want to talk to you about today is how's that affected the way we think about treatment. And so what we end up doing now is think about Alzheimer's in terms of biomarkers. Whether you have amyloid and tau in the brain, not whether or not you have symptoms. So every biomarker in this framework is classified as present or absent. So you can have amyloid in your brain, in which case you're A+, or you can have tau in your brain, in which case you're T+. And by tau in your brain and T+, I don't mean that little tau in the medial temporal lobe that we all get as we age. I mean tau that's substantially outside the medial temporal lobe, where we think it's been triggered by amyloid. And so if you are A+, T+, that is, you have high levels of amyloid and high levels of tau, we think that's good enough to call it Alzheimer's disease, even if a person doesn't have symptoms. Because there's strong evidence that if we did a neuropathology exam on a person in that situation, we would find those plaques and tangles. And that is Alzheimer's disease, according to our current theories. So this opens the door to treating asymptomatic people with drugs that target amyloid and also that target tau. So let me show you a study we were part of that came out just a few months ago. And these was a large data set that was assembled by a group of scientists where they took 1,300 cognitively normal older people who had baseline PET scans of amyloid and tau. And remember, these were all cognitively normal. They followed them over time and asked, what's the chance that these people are going to stay normal versus the chance that they're going to develop MCI, which again, remember, MCI a precursor to Alzheimer's in most cases. So this is a graph, and this red line is no amyloid and no tau in the brain. And this staying along this line means the people stayed normal. They didn't develop MCI. This is amyloid without tau, and you can see that some of these people developed mild cognitive impairment over time, but not that many. And again, I think you can see where this is leading. These are the groups who had amyloid and tau in their brain. This was the two lines are tau measured somewhat differently, but the bottom line is these were both A+, T+, and these folks developed mild cognitive impairment over time, such that almost 3/4 of them developed mild cognitive impairment if they had amyloid and tau in the brain. So just to look at this another way, this is just the, I guess every time I use this. So another way to look at this is what we call hazard ratios. And the hazard ratio for being A+, T+ is 20 times greater for getting mild cognitive impairment, or MCI, than not having amyloid or tau in the brain. So just think about this, right? If you're cognitively normal and you're A+, T+, and we have a way to intervene by lowering amyloid or tau, wouldn't that be the group to treat? That the people with asymptomatic, no symptoms, but A+, T+. So that's the whole idea here, that these people would be the ones we might have the most effect on in terms of treating. So that's where we are in many ways. We're targeting people with elevated biomarkers. We're using antibodies now to lower amyloid. When I say we, I really have nothing to do with this. My interest is in the biomarkers and the aging stuff, but now I'm going to tell you something about clinical trials that I've learned over the last few years, but it's not something I've done. Just be honest about that. So what we do in the field is to lower amyloid with what we call immunotherapy, because we infuse antibodies into people that remove the amyloid, and then we follow them for clinical improvement. But I probably don't have to tell you, there have been a lot of failed clinical trials. And I had a slide here that listed all the failed clinical trials, but I just took it out. It's too depressing. Let's talk about one controversial clinical trial. And I just going to give you a peek behind the screen. So you've heard of aducanumab and Aduhelm, and this drug was controversial from day one. And the New York Times had a series of articles on it, made the front page. People want an Alzheimer's drug. This isn't the one. This was an op-ed piece by a colleague of mine. He didn't think this was a good drug. Then the FDA approved it, despite the fact that a lot of people didn't think it really worked. And then some of the people on the FDA advisory board who gave the advice to the FDA not to approve the drug quit because the FDA approved the drug despite their advice. So what actually happened? So it's an interesting drug. There were two studies. They were called Emerge and Engage, and each study recruited almost 1,500 people, and they were treated with 2 different doses of aducanumab or placebo. And this is an earlier study that just shows the PET scans at baseline with different doses of the drug, and you can see that the amyloid cleared out of the brain. And this wasn't just one PET scan. This is real data. And here is the Emerge study. This is time, and this is the amount of amyloid in the brain. So over time, the placebo group actually deposited a bit more amyloid, but over time, the treated groups at the 2 doses cleared the amyloid pretty well, not 100% from the brain. That's the Emerge study, and that's the Engage study. So this drug removed amyloid. And here's the clinical outcome. So in the Emerge study, this is the placebo, and these are the 2 doses of the drug. And you can see that everyone got worse, but the placebo group got worser than the group treated with the drug. That was in the Emerge study, but in the Engage study, there was no difference. So there was a lot of discussion about this. One of the studies was positive, one of the studies was negative. The improvement was small. Does it have real-world effects? Is it going to be a drug to help people? And that's what the argument was about, fundamentally. And at the end of the day, the FDA decided to approve it based on the fact that it lowered amyloid, because the FDA was reasonably confident that lowering amyloid is the right thing to do. And they're still arguing about that. We're all arguing about that. And it's complicated because this FDA decision that didn't produce clear clinical benefit led to the fact that Medicare decided we're not going to pay for it in most situations. So this drug hasn't been taken up really because it lowered amyloid, but it didn't improve people. And again, the people who are skeptical about amyloid use this as an argument that, well, maybe we're barking up the wrong tree here, and aducanumab is a good example of that. So let me skip that and just go on to the next slide, because there's more. So why have these drugs failed, and why are the trials so many of them negative? And here are many of the arguments. One is amyloid is not the instigator. It's another molecule. It's not amyloid, it's something else, and we've been misled for a long time. The other is that tau is the actual culprit. Why are you chasing amyloid when I've shown you that tau is doing a lot of bad things in the brain? Clinical trials haven't lowered amyloid enough. We need stronger drugs to lower amyloid more, or it's more complicated than just amyloid. So I'm going to really get you into the scientific controversy here. So this is the first one. Amyloid is not the instigator, there's another cause. All right, now the confession. I'm a subscriber to the amyloid hypothesis. I think it's a very cogent theory of what causes Alzheimer's disease. At least it gives us an approach to therapy. And if amyloid isn't the instigator, tell me what is. It's been 20 years and we don't have another molecule. There's not a good story for another place to attack this problem. So I'm going to leave this. So now tau is the actual culprit. Well, for sure it is in many ways. But this is a graph of change in tau over time. There's a lot of data in this graph. This is a big study. This is the Alzheimer's disease neuroimaging study, or ADNI. This is age. And what you can see is these little lines are individual people over time. And you can see the people up here. I don't know if you can see that in the back, but these are the people who have a lot of tau in the brain, and their tau is going up. And all of these people who have a lot of tau in the brain, where the tau is going up, have amyloid in the brain. It's very unusual to see people with high, elevated tau who don't have amyloid in the brain. And that's also on my next slide that shows you people, just one particular PET scan. That red line is the level of tau positivity, if you will. The lightly colored dots are people without amyloid in the brain. The dark dots are the people with amyloid in the brain. And you can see that all of these people have high tau. All of these ones way up here, they all have high tau. And you can see that almost every one of them is amyloid positive. They're all the black dots. And these gray dots are amyloid negative. So you do see it. I don't want to mislead you. There are some people who have high tau in the brain without amyloid, but almost everyone who has high tau in the brain has amyloid. So again, yes, it's tau, it's not amyloid, but you don't get to this point with tau without having amyloid in your brain. So how about this one? Clinical trials haven't lowered amyloid enough. I think we're all beginning to agree this is probably part of the story. This is just one graph that shows a number of clinical trials over the last 5 or 10 years. And here is the amount of amyloid lowering, and here is the change in cognition. So over here in the lower left is more amyloid lowering, and over here on the bottom is better cognition. So it's not perfect, obviously, but in general, the trend of this relationship is that the more you lowered amyloid, the less cognitive change there was over time. So just want to, I didn't say this clearly, but I want to make this point clear. None of these people with less cognitive change are getting better. So these drugs are not making anyone better. What they're doing is slowing the progression, making them get worse more slowly. So in general, the more amyloid lowering, the more clinical improvement. So let me tell you about a result that came out just in December. And this was a drug called lecanemab. It's another immunotherapy. It was a big trial, 2,000 people. And what you're seeing here is the amyloid lowering. And this drug really walloped amyloid. It really, really lowered it in the brain. It ended up that the mean amyloid level was basically right around the border of being positive. So lots of people in this study cleared all the amyloid, at least that we could measure, out of their brain. And in this study, there was almost a 30% slowing in the rate of cognitive decline. And this study was positive. It hit its endpoints, and it's generally felt to be a big success. Although we're still talking about whether the changes are completely meaningful. This is lecanemab. I'm going to come back to lecanemab because it's an important clinical trial result. Another drug is called donanemab. This was the result of a phase 2 study a couple of years ago. Phase 2 is very small, generally done to assess dosing and safety and not always to bring to the FDA. But this is another drug that really walloped amyloid. 70% of people in this study had negative scans. Again, you can see the placebo group didn't clear out the amyloid, but here the amyloid is going down and really dramatically cleared. And in this phase 2 study, again, there was a significant treatment effect that here the drug group didn't decline. I'm sorry, decline is worse. The placebo group declined more than the treated group. This was a small study, not enough to approve, but literally last week, on May 3rd, the phase 3, the big study came out. And in this study, really the results were very similar. The people who were treated with this drug showed about a 35% slowing. All the endpoints were positive, and there was a dramatic reduction in amyloid. So This donanemab looks like another winner along with lecanemab, at least as far as lowering amyloid and slowing the progression of Alzheimer's disease. So the other thing, if you really think this through, you might ask the question, what happens to tau when we lower the amyloid? And this is results from the first donanemab study that I'll just go through really quickly that basically showed that the more you cleared out amyloid, the lower the tau was in the brain. And that's really the same thing here. So clearing out amyloid seems to actually have an effect on the downstream things that are happening with tau. And so that also supports this idea that amyloid is driving these tau changes. Okay, as Dr. Vassar pointed out, these drugs come with side effects. And all of these drugs that are immunotherapies require, at least now, IV infusions. That's going to change. There'll be some subcutaneous drugs. There may be other ways of doing this. And immunotherapy is only the first chapter in this very long story. I'm sure there'll be other approaches to lowering amyloid. But what happens with these intravenous infusions is you get this reaction sometimes in the brain called ARIA, amyloid-related imaging abnormalities. And this is brain swelling. It's usually asymptomatic, usually reverses with discontinuing the drug. But in all the clinical trials, the people who've been getting these drugs have been monitored with MRI. And it's not rare. You can see it's roughly 20 to 30% of people on these drugs develop ARIA. And both donanemab and lecanemab have seen deaths associated with this. Not many, 2 in the study, but death. So this is not perfect. So that's the part about lowering amyloid. And let me just end with this, that it's more complicated, because of course it's more complicated. Alzheimer's is a very complicated disease. Dementia is very complicated. And there are other pathologies in the brains of older people. One of them is stroke, cerebral infarction. I'm showing you an MRI scan. There are other kinds of infarcts we call microinfarcts that are visible on pathology, but we can't see them during life on an MRI scan. There's another protein that aggregates called TDP-43 that we think is associated with memory loss. We don't understand much about this protein. There's another protein called alpha-synuclein, which is also deposited in the brain that's associated with movement disorders and Parkinson's disease. And all of these things can occur in people who have Alzheimer's disease and probably contribute to the dementia, and maybe a reason that some people don't improve when we treat them. And in fact, when you look at brain banks, when you look at what the tissue looks like in people who've died with Alzheimer's disease, practically none of them have pure Alzheimer's. So this is the pie chart of almost 450 brain autopsies, and you see a relatively small number of people had pure Alzheimer's. This is the group that has Alzheimer's disease and vascular causes like stroke. And this is the group that has Alzheimer's disease, other degenerations like this TDP-43 and alpha-synuclein and vascular disease. So these other proteins and vascular disease are a big part of causing dementia, and they may be something that complicates the picture of treating amyloid. So that kind of thinking has led to other approaches to therapy, and I'll just tell you really quickly about this study called the Pointer Study, which is a lifestyle intervention. And this is being done out of Wake Forest University. They're randomizing people to a self-guided lifestyle intervention or a structured intervention that's targeted on exercise, nutrition, cognitive stimulation, and health coaching. And the goal is to see if this kind of multi-domain, throw the kitchen sink at people, and these are folks who don't have Alzheimer's, but people who are experiencing mild degrees of cognitive loss will improve. And at Berkeley, we're actually following these people with PET scans to see if they can, maybe there'll be an effect on amyloid, or maybe there'll be an effect on tau. So the lifestyle changes actually protect the brain. Can we measure changes in all of these biomarkers that I've been talking to you about? Okay, so that's my last slide. Where do we stand? Well, aducanumab and lecanemab are approved by the FDA under something called the accelerated pathway. And what that means is it was approved because it lowers amyloid, but it's not really fully approved. It's kind of got this sort of intermediate status. But donanemab and lecanemab in this second study, this big study that just came out, these are both, we think, I don't, let me caveat, I don't know, don't buy stock because of me. Donanemab and lecanemab, we think, are likely to receive full approval because they produce clinical benefit. But these are not miracle drugs. They don't cure Alzheimer's disease. They slow progression. Maybe they'll be more effective if we can give them early. I didn't say this, and I realize I left this a big problem, but all the people in these trials had symptoms, right? These are all people with early, mild Alzheimer's, but they all had symptoms. So there are studies underway now to see what happens to people without symptoms, and that may be where we get the most bang for the buck. The real significance of this improvement isn't still clear. Maybe if people are on it for a long term, it'll be really even better. Maybe early treatment will be even better. And there are clearly downsides to treatment that we have to really be concerned about. There are lots of drugs in the pipeline, and plasma measurements are coming along. So this is just the drug pipeline in 2021, and each of these dots is a drug. So there's lots of work on developing new approaches, and there are going to be new approaches to lowering amyloid, to lowering tau, and so forth. And then the benefit of having these measurements in the plasma is that it's not quite ready yet, but at some point we'll be able to do blood tests to tell whether amyloid and tau are elevated in a person. And that, again, combining with the idea of really early treatment, may be a way to get all of this, this kind of thing started at a very early stage of Alzheimer's disease. So I'll end with two things. One is I'm optimistic. I've been working in this field for 40 years, and I've never been more optimistic. But I should also tell you that at heart, I'm an optimist. And then the last thing is I just want to thank all the people who worked in my lab. This is the thing I'm most proud of. I didn't really brag up here, but I am proud of all the people who worked in my lab. This is our alumni reception a year ago at the Alzheimer's meeting, and it's all the young people at places like the Mendelson Center and Berkeley and all around the world who are doing all this work, and I hope will lead to positive, pragmatic results. Thank you.
Thank you, Bill, for a great talk. And so we're going to have questions from the audience. And I think we have a mic. We have a mic that we can give to people.
Yeah, so if you have a question, feel free to raise your hand. And we have mic runners throughout the room, and they'll bring a mic to you. And just to let you know, we'll just do a little bit shorter of a Q&A just to stay on track a little bit. And we're going to take a 10-minute break, and then we'll start the afternoon session. And we'll give a good start time for that. Does anybody have a question? Raise your hand. Yes, sir.
Yes? This was an excellent presentation. Thank you so much. I have one question about maybe the change in FDA's approach to drug approval. Because you also said, even though there was no clinical outcome, but now based on lowering the levels of the toxic proteins, now FDA gave the approval. Recently, something very similar happened in the field of ALS. And do you think that's how the FDA approval is moving forward? And that also maybe puts the biomarker studies even more at the forefront, that we need to understand the underlying causes of the disease. And maybe some drugs may be good for Alzheimer's, ALS, Parkinson's, and now that we don't actually have the drugs for the disease, but for the mechanism. What do you think?
Well, I mean, you said a lot. I'll start with the last, and I think the most important thing is that we have the drugs for the mechanism, because we have drugs for Alzheimer's disease. The cholinergic drugs, and they they don't do that much because they were focused on Alzheimer's disease and not the mechanism. So I think that is really important. The idea of treating for a surrogate biomarker is actually very, very old. The FDA, it started during HIV, and it actually started because there were no treatments for HIV. People were dying, and activists were able to convince the FDA that if you change T-cell counts, the people would live longer. And they were right. So drugs were approved based on changes in T-cell counts because who wanted to wait for people to die to see if the drug worked or not? So that was the beginning, and we're still in this phase. I don't know what to say about like what the future is. There's a lot of controversy about this, and some people think that lowering amyloid is the way to go, and we should give the decision making to patients and doctors and their families. Other people think just lowering a biomarker, changing a biomarker without clinical change, opens the door to other problems, which it does. It's a trade-off. So I don't know the answer, but I think that's where we're at.
Thank you again. Excuse me. My simple, practical question is, I saw one mention of a dollar amount of $11,000 a month. What kind of research is done in conjunction with the drug companies on the price factor before we get government insurance?
Yeah. So I didn't talk about the prices. Again, the health economics of this is really, really complicated. But, these drugs, these immunotherapies are expensive. And I think that's one of the complicating issues is, how much should we pay in exchange, and in exchange, what should we expect to receive, right? You bring up a really important problem. There's a lot of interest in this. There's a whole field of health economics, right, that where people study these questions and weigh in on them. I'm just not, I'm not conversant with that field, so I don't know anything more than the common sense, practical kinds of things that you all probably think about. And, if you have Alzheimer's disease, you want to be treated with these drugs. So that's kind of my answer. But it is going to be expensive.
Good morning. Good morning. I'm a layperson, and I commend you for a good job of describing the graphs to us in terms, or to me, in terms that I can understand. So thank you.
Thank you.
I have a history of Alzheimer's in my family, and I'm getting to the age where I'm getting concerned about it. And I'm trying to learn more, but also contribute. And, the good news, bad news is in blood screenings that I do, I don't show any signs of interest for the researchers. How reliable are those blood screens initially? Should I push harder to try and be tested so that I can participate, or should I just leave well enough alone? Does that make sense?
Yeah, it makes sense. And, I know that I'm going to be saying I don't know a lot to your questions, and I might as well start now. I don't know because I don't know what. First of all, when you ask sort of how good are these tests? They're pretty good at predicting amyloid in the brain, but they're not perfect. So it's definitely possible that you're a false negative, that you really do have amyloid in the brain, but they're going to be better. They will get better over time. So I think that's, and they'll never be perfect, right? But I would say on the flip side, what do you want to get out of this? If you want to be a research patient, it's admirable, it's altruistic, right? But it's very different than asking, should I be treated with a drug? At this point, you probably would get as much out of getting memory tests, for the next 5 years. I actually don't want to suggest you do that because I probably wouldn't even advise that, but I think that is another way you could get a handle on what's happening to you.
Hi, I'm also a layperson, and it was a great presentation. Regarding amyloid, has there been any test that takes amyloid to zero, or is that not possible, or are there other consequences in doing that?
Yeah, so the drugs that I showed you, many of the people treated with those drugs got to, I use quotes for zero because our limits of detection are limited with a PET scan. They may still have amyloid in the brain, and frankly, they probably do. We just can't measure it. But for all intents and purposes, many people put on these recent drugs cleared the amyloid out of the brain to the point where it was close to zero. As far as we know, there are no negative consequences to that, other than the side effects of the drugs that I've told you about. Those are clearly negative consequences. But the A-beta protein that we clear out of the brain doesn't seem to be doing something that, that would make its removal harmful.
Hello. Knowing that the drugs are or will be available, it makes sense to me that hopefully Medicare will step in because they have 5 different tiers, I think, of medical expenses. And have you heard any possibility of that being a Medicare for
Yeah,
the
I mean-
65 and older?
I mean, that's what we're waiting to hear, you know. First of all, the FDA hasn't fully approved the drug, so there's still the FDA review that has to go on. And once that happens, then Medicare will make a decision. And I have no idea what Medicare will do.
Hi, thank you for your information. I'm beginning this Alzheimer's journey with my mother, and I am curious about and I see what the type of drugs that are coming, but what are the efficacies of the existing drugs, and if there are any kind of way to determine, does an individual have a choice of which drug that they're automatically prescribed? And are there any kind of cultural differences of how the existing drugs react with, you know, people of different ethnicities and things like that, so that we can get a better baseline and start when we are doing this with our parents and ourselves, you know, where can we go to see about the charts of what's already out there and how it works?
Yeah, I mean, thank you for bringing that up because it does raise a point that I really didn't have time to get into. But one of the limitations of everything that I've told you today is that most of the research that we've done in this field, and I say we, pretty much everyone, not everyone, but most of us, is limited to majority types of populations. We don't have a good idea of how Alzheimer's disease evolves in groups that have been, you know, generally disadvantaged or underrepresented in medical research and medical care and so forth. You know, people of color, basically, in the United States. And so it's very difficult to say whether or not different groups of people might have different responses to this drug. So far, there doesn't seem to be a lot of evidence for that, but we don't have enough data. And the good news, you know, is that, you know, we've all become aware of this. So we're spending a lot of effort to try to make our research sample more diverse and more representative of the people in the United States who have Alzheimer's disease. And so I'm hoping that that will be something that improves. I mean, with regard to your other part of your question, there are medications for treating Alzheimer's. Some of them treat the symptoms. Some of them may treat some of the chemical imbalance. None of them are super effective, but most physicians who treat older people are aware of these drugs. And I think no one should, I mean, you used the phrase, which, you know, no one should be automatically put on a drug for anything, but especially Alzheimer's. I think there are always trade-offs with drugs. Most of these drugs are used when people have things like depression or other kinds of behavioral problems, and those require conversations with a doctor. And you know, those treatments are absolutely out there and available.
Yes, I've practiced pharmacy for over 34 years, and I retired in 2018. And I noticed with the new products coming out, I'd like to know how this aducanumab is administered.
Yeah.
Now, I know that there are some who have to go through dialysis, and that would be a very uncomfortable situation to put people in if they had to go regularly like that. And if the patient is getting positive results, do you keep the same dosage of medication, or does it come down over a period of time?
Yeah, those are good questions. So right now, these drugs are administered intravenously, and people have to literally come into an infusion clinic, like a cancer infusion sort of thing. So you literally have to get them infused. I mean, I think as they roll out, there may be more convenient ways to do this, but ultimately, this is an intravenous infusion. There are going to be people who can't get the drug for various reasons. I don't know about dialysis, but it sounds like it could be a problem giving this drug in that setting. But then the other part of the question is actually really interesting, and I was going to talk about it, but decided I didn't have time. One of the models for giving these drugs is that you would infuse it for a period of time and then stop, and then watch and see what happened. And maybe you need sort of a booster treatment, but that could be as long as a year or even 2, right? So that people would not necessarily have to be getting these infusions every 6 weeks or 2 months for the rest of their lives. They might be able to go off the drug for a period of time, and potentially a long period of time.
Well, I'm sorry, but, for the sake of time, I think we should wrap it up. If you have questions for Bill, I'm sure he'd be happy to answer them during the break. We're going to take a 10-minute break. So let's everybody be back here at about, let's say 10 after noon. Thanks, Bill.
Yeah.